We're going to go ahead and get started with our program. I'm sure we'll have many more that join. I know that we had some problems with our event link, and so we just want to make sure that everybody has an opportunity to jump on. Rebecca, can you share your screen, and we'll go ahead and start the program?
Yeah.
I'm Sonia Negley, and I'm with METAvivor. I'm the executive director. And today we're going to hear a little bit about testing. If you guys can save your questions till the end, or what's even better is if you want to go ahead and put them in the chat, then we'll go through those questions at the end of the program. We ask that you stay muted just so everybody can hear what's going on in the program. And I know last time we had a ton of questions, so please feel free to go ahead and put those in the chat as we move forward with sharing this new testing with you. If you don't know Rebecca, she was one of our researchers that was funded through METAvivor. She's now she's like the medical liaison with Natera. And so we're very excited to have her aboard. She's a PhD. She understands METAvivor and she understands metastatic breast cancer, which we love. So if there is anything that you guys, any questions that you have centered around this testing, please be sure to ask those questions. Or if there's any questions you have of METAvivor. This is the second in our Lunch and Learn series, and we'll have one more next Wednesday that will conclude our testing, the latest in the cutting edge testing for metastatic breast cancer. There's some matching that will be talked about in this session and then also in our next session, and this can help predict what may be the best next treatment option for you and your specific type of metastatic breast cancer. We've already had a question in the chat that says, will this recording be shared? Yes, it will. We'll share them at the end of the series and they'll come out. We'll send them to you through email, and then we'll also have them on our website. So Rebecca, thank you so much for being with us today, and I'm going to turn it over to you.
Okay, great. Thank you so much, Sonia. And it's really an honor to be invited back again for part 2. Like Sonia had mentioned, I was previously funded by METAvivor, so your group is very special to me. And metastatic breast cancer really was my passion for research. So it's really an honor to be here today and to be interacting with all of you again. And I appreciate all of you that have come back from last week. Your questions were awesome and they're always appreciated. So I'm really looking forward to the discussion at the end of the presentation. And also, I just want to briefly introduce my medical director, Dr. Angel Rodriguez, has also joined us on the call. So he will also be participating in the discussion at the end. Angel is a medical oncologist. His specialty is in breast. And so really happy to have him on here today with us. Okay, so I'm going to go ahead and get started. And I think you can all see my slides okay. If anything happens, if my audio cuts out or slides, please let me know. Okay, so before we get into Altera, which is our comprehensive genomic profiling, I just want to do a refresher on Signatera. So this is what we covered last week in part 1. So if you remember, this is our molecular residual disease assay. So it is nothing like a targeted panel or comprehensive genomic panel. So this test, just to remind you, it's a non-invasive tool. It's really used for disease monitoring in the surveillance space or treatment response monitoring. And so this test really is able to use DNA that is shed into the blood from the tumor cells. So it can determine if you still have cancer cells somewhere in your body. And it really gives that global overall picture of what's going on. And we're able, with this test, we can detect cancer recurrence earlier than before and can help improve confidence in your scans. If you have a negative scan and also a negative Signatera, helps give you a more well-rounded picture of what's going on in your body and maybe even give you some more confidence moving forward, and also to let you know if your treatment's working. So using Signatera, we can see that if as ctDNA levels rise or fall based on the treatment that you're getting, we can use that kind of as an idea of how your tumor might be responding to that particular treatment. Okay. So just a refresher on how it's built. So many of you have heard of liquid biopsies. So our test is really built off of the tumor tissue, not just the blood. And this is really important because we discussed last week that when we build it off of the actual tumor tissue, we're able to find the mutations or those variants that we talked about that are specific to the tumor. So we use blood to filter out anything that might be germline or naturally occurring in your body, and we are focusing only on what is in that cancer. So it is very, very specific to that tumor only. And once that test is built, it only works for you and your tumor. It can't be used for anyone else, and it can't be used for any new tumors that would pop up. It is specifically for that tumor. That's how specific our test is once we build it. And then after it's built, all you need are additional blood draws determined by your clinician, depending on what point you are in your treatment and how often they want to assay and look for ctDNA levels in your body. But at that point, all that are needed are routine follow-up blood tests. Okay, so Altera really is part of the expansion. If you remember last week, I talked about how we kind of have this whole portfolio covering the whole cancer care continuum. So we have our cancer screening. It's our hereditary cancer testing, which we won't be covering that today, but we have that at the beginning. We also have our Signatera, which I mentioned tracks molecular residual disease by tracking the circulating tumor DNA in the blood, also looking for potential of recurrence, and to see how you're responding to your treatment. But we also have Altera. So Altera is our tumor gene panel. It's a comprehensive genomic profiling panel, and it is a tool to help assist your provider in new potential cancer therapy selections based on potential mutations or things that we might find unique to your tumor. It can also point them to potential clinical trials that you might be eligible for, and also some new targetable mutations that they might not have known that your tumor has, but it could point them to therapies that might already be FDA approved. So we're going to dive into that further. So first, before we even get started, what is CGP, Comprehensive Genomic Profiling, and how can it help you? So to really kind of understand this, we need to understand what's going on in the tumor and what are these mutations specifically. So CGP, as I'll just refer to it as, which is, again, the Comprehensive Genomic Profiling. This is really a blood or tumor test that's used to detect relevant mutations found in your tumor. So mutations are one large general class, right? These are changes in your DNA sequence that could be contributing to some sort of change in the cell. They could be either beneficial or they could be harmful. And of these mutations, there's a couple different classes. There are what are known as the driver mutations. And so that's why we have this picture of the car here on the slide to kind of give you an idea. So driver mutations, it's exactly what they are. They're driving it. They're driving the course of the tumor, its aggressiveness, its spread, that sort of thing. So in these driver mutations, these changes, they can make cells proliferate, grow more, or go to distant sites. Then you've got these passenger mutations. So these are the ones sitting in the passenger seat. They're along for the ride. And so their changes really don't contribute so much to the cancer growth, but they're used more to determine the lineage of the tumor. And so that you can kind of get that fingerprint to track them over time. And so understanding these mutations can really help your oncologist create a personalized treatment plan with potentially better outcomes for you. Okay. So currently right now, many of you might be familiar with, we have these things called guidelines. So these are created by NCCN. And so this is for the National Cancer Center Network. So these are guidelines that are created for all different tumor types, and they really help physicians or providers know how should you be treating your patient during different stages of the disease. And so really for recurrent or metastatic disease, it's actually recommended that you do this biomarker testing. So really they recommend that there should be a biopsy of at least the first recurrence, or potentially rebiopsying if there is progression, and obviously reevaluate the marker, the receptor status of the tumor. So we talked about this last week, and some of you asked some excellent questions, because we know that there can be what we call receptor discordance. So maybe a tumor was originally hormone receptor positive, it goes elsewhere and suddenly it's negative. And so really that's where, this testing comes into play. It's important to know if that tumor, once it's landed in a distant site, if it still has those receptors present, because if not, then that might change the course of therapy. And this is also encompassing the comprehensive germline and somatic profiling. So somatic profiling, this is what Altera is doing. So this is looking for those mutations, those driver mutations that are present only in your tumor. And so really, this is being used to identify these candidates for additional targeted therapies. And as I mentioned, this is really what is recommended based on guidelines for stage 4 or recurrent disease. So what is Altera? How does Altera come into play here? So Altera is really a test that's used to help identify therapeutic selections and potential available clinical trials based on the genetics of your tumor. So as I mentioned, this is known as Comprehensive Genomic Profiling, or CGP. Important to note, this is different from targeted panels. Targeted panels have a set number of genes, and that is all they look at. Comprehensive genomic profiling is looking at all of your genes, all over 20,000 of them. And so Altera really tests for all of these genes, and then it looks for the ones that are relevant to your cancer that could potentially impact your cancer treatment. So just kind of a snapshot of what it's looking at. So I don't want to dive into the weeds too much here. I would like to keep it high level, but I know for your group, all of you are exceptionally well read in this area. And I know just based on all the excellent questions you've asked me over the years, I think that you probably would want to know the types of targets that we're looking at. So we're using a couple different sequencing approaches here where we can find mutations, but we can also find what are known as fusions. So fusions are when two genes come together and make a new gene, and then therefore they can make a new protein that can either have a bad effect, or most often it's a bad effect. So when two genes come together, you might end up losing what's known as something like a tumor suppressor. So those are genes that help put the brakes on cell division and growth. Or you could have maybe an oncogene forming. So those are genes that help promote proliferation, spread, growth, that kind of thing. So these fusion genes, we know of them. There are different classes of them, and there are some tumors that have them more than others. And so our test can actually help pick up on those fusions, both novel and classified ones. And we also have what's known as a boosted coverage. So there are 440 what we call clinically actionable genes. So these are genes with known FDA approved inhibitors or drugs. And so these ones we actually will cover even more in the test, just to see if they might be present, because if they are, then we can report that to your provider and potentially give them another option for treatment. And we also look for things called microsatellite instability and tumor mutational burden. So microsatellite instability, these actually result in the DNA when there are issues with what we call mismatch repairs. So if you imagine, if you're looking at a paper and you see different typos, sometimes typos can appear in the genetic code. And we have proteins that will go in and fix these typos in the genetic code. However, in cancer cells, this machinery is usually hijacked. And so you're unable to fix those typos. And so they remain, and they actually start to repeat. So we end up getting these repeated sequences. And so those obviously accumulate into more mutations. And so that's where we also look at what's known as tumor mutational burden. So these are the number of mutations that we can find in a particular tumor. So the more mutations you have, the worse that tumor is at that particular point. But our test can cover all of these different areas. And as I mentioned, based on what we find from these targets, we can report, and I'll show you an example report in a little bit here, where it will show FDA approved treatments for these specific targets, or even novel approaches when standard of care is exhausted. So, often and sometimes in the metastatic setting, if you make it past maybe second or third line, that's when you and your provider might be looking for other options. And so that's really where something like a test like this might be able to come into play and offer you other potential options. And then in addition, this can also point you to clinical trials. So really, ultimately, all of this, it comes down to your provider and your care team. And many of you probably have multidisciplinary care teams. So they know your entire health history. So really, this test isn't exactly a roadmap to say, hey, do exactly this, but it's to give you another option so that you, with your providers and your shared decision-making process, can decide if maybe this is the right, another alternative for you. And among that are clinical trials. So this result could point you to a clinical trial. Maybe there might be one in your area that will give you another option. Okay. And so really, what does this mean? So all of you know that we are really in the era of precision medicine, which is really exciting because at this particular, up until now, most tumors and most patients have been treated very similarly. But we know that the tumor in one particular person, even if they might be the same subtype, is not necessarily the same in the next person. So kind of that one size fits all approach of how you should treat patients and what you should do, it's being questioned because now we have access to all of this new sequencing technology, which is incredibly exciting. And I'm sure all of you have seen in the news, the human genome is now has been fully sequenced at this point. So this is really exciting. We are, at the beginning of so much that's coming, and a lot of this is in the precision medicine area. So knowing what's going on in your tumor can help make a more informed decision specific to your cancer, can help direct selection of any available therapies, both new and old. Sometimes drugs can be repurposed if there is a similar target. And it can also rule out other therapies that might be ineffective. For example, if you have a mutation in your tumor that might be resistant to an already standard of care therapy, then they know that, hey, this might not work for your tumor. And again, as I mentioned, helping to identify available clinical trials, other options. So as I mentioned, like historically, most cancers were all kind of treated the same type of way. And there was this idea that more must be better. So, a lot of patients were getting a lot of chemotherapy that damages both healthy and cancer cells. And some patients weren't always responding to that, or, again, getting back to their particular tumor biology, maybe they might be resistant to this type of therapy. But if you're just constantly hitting everybody with the same therapy the same way, we're not going to have the best outcomes. And so that's really where talking about precision medicine, taking this biomarker-driven therapy selection approach is really the best way to move forward. And I'm sure everyone on this call is familiar now with precision medicine, and you all agree with this. But really trying to identify pathways or mutations that are unique to somebody's tumor, this is really the way to go, because not all cancers of the same type should be receiving the same treatment just based on their mutational profiles, right? Because they might be different. And so being able to do this biomarker-driven approach, we can use this to predict benefit and potential resistance to specific therapies. So I just want to show you a couple example reports of what Altera looks like. So remember last week I showed you an example report of what Signatera is, our molecular residual disease. Well, now I'm going to show you a sample report of our comprehensive genomic profiling. So what you'll see here, and this is actually what your provider will get. So they'll get a quick snapshot. So they'll get an idea if you have a high tumor mutational burden or not. If those microsatellites, so if you remember, these are those repeats in your DNA sequence, if they're low, stable, high, they'll also see if there are clinical trials potentially available for you. And then they'll also get kind of a summary of the different targets that have popped up. So in this first example, this is not breast. I'll show you breast in a moment. This is a malignant melanoma example, but we like to show this one because in this particular tumor, there were 9 actionable targets. So actionable meaning that there are already FDA approved therapies that could be used to target some of these genes. And so if you look down here, it gives you a summary of these genomic targets, and it will let you know if they're FDA approved drugs. And then it will also let you know if there are clinical trials. If the drug is not necessarily yet FDA approved, but it's in clinical trial, your doctor, if they determine this is the right option for you, might be able to help you get enrolled. We've seen that patients that have high tumor mutational burden actually respond very well when you give them immunotherapy. So letting your doctor see this is also very helpful as well, because then they know that, hey, you might be a candidate for immunotherapy. Okay. And so moving on to the next example, you'll see it's very similar. So this is with breast cancer. And so if you see this genomic snapshot, same thing. It gives your provider an idea of what's going on. Do you have that high tumor mutation burden? Are there potential clinical trials available for you? And are there any actionable targets? So for this particular patient, there was actually this interesting ESR1 fusion. So ESR1 is just a gene, is the gene name for estrogen receptor. And so estrogen receptor has been shown to fuse sometimes with other genes. So this particular gene here, CCDC170, this gene has been implicated in breast cancer and also shown to serve a role in bone mineral density, which is really interesting. And so this particular fusion, so this popped up for this patient. And so this kind of let the provider know, hey, these drugs, these aromatase inhibitors are probably not going to be effective for this patient because they have this particular fusion. And this fusion tends to make them their tumor resistant to these types of therapies. So just kind of, again, the last one was kind of pointing to potential treatment options. This can also show you, hey, what might not work for the patient. So I think this is kind of a nice example to show in that respect. Okay, so getting into, how would your provider order Signatera and Altera? So Altera is really no different. It needs to be ordered by your doctor. Patients cannot directly order this. But one of the things that's kind of exciting about Altera and Signatera is that we can run both tests off of one piece of tissue. And so this is really important when maybe you don't have a lot of tissue present, or your provider, maybe there are other tests, or maybe you're involved in a research study, you've decided to join something like that, and they might need some of your tumor tissue for that. So this is a great way to help preserve that and get more information out of one piece or one sample. And so really what we would just need, again, at diagnosis is that tumor tissue. Again, we discussed this last week, you really need a minimum of 20% tumor content in that sample for it to be successful. And so we get that tumor tissue, we get the blood, because if you remember, we use the blood to filter out any kind of germline variant because we want what is only unique to your tumor. And then moving forward, and this is actually where, Altera would stop, because Altera is a one-time test. But with Signatera, we could, again, like I mentioned earlier, we would do serial monitoring of the ctDNA levels in your blood, so we can get an idea of, is the cancer possibly recurring? Are you or are you not responding to your treatment? And then if you recur again, if your provider did not order Altera initially, they could order it at the recurrence. So get an idea of, has your tumor developed any potentially new acquired mutations over time based on the different treatments that it's been given. And so, these are the different time points or places in your cancer journey where you could use both of these tests. And as I mentioned, really the benefit here is that both of these tests can be run off of one sample. So just to kind of go into the blood draws again, maybe some of you live in rural areas. It's not so easy to always get to your provider's offices. We do have this mobile phlebotomy service We've performed over 10,000 in-home blood draws. You know, often it's at people's homes or, you know, other locations that they choose that they might, you know, that might be easier for them. You know, if perhaps you're at work, you can't get out of work, maybe they can come to you at your work location. But this is another option. And I know a lot of patients and providers appreciate this, especially those where maybe at the moment you've got limited mobility or you live in a more rural area and have to travel further to get to your clinician's office. So I just like to share this too. So again, this is really our page for you to go and look up more information about Natera and our particular tests with Altera and Signatera. And again, I know this group very well, and I know that you all do your research and you like to look at this. So we just wanted to share this resource with you, and also, you know, offer, you know, we will send materials to Sonia afterwards if you want to share them with your doctor, so that you could begin the discussion. If you would like to also use Altera in addition to Signatera, again, this is something that your provider needs to order. And we also have this specific email that is only for patients. So you can email this email oncologypc@natera.com at any time with any questions. And we have, you know, licensed genetic counselors and patient advisors that are ready to answer any particular questions that you might have. And so before we get into the discussion part, one of the things that my colleagues, Jamie and Angel, we were talking about this, we'd love to ask you because we would like to know, how could Natera possibly support your needs? You know, what educational resources would you appreciate, especially in the situation with this Altera CGP? You know, last week I shared some patient resources that we had for Signatera that I know Sonia's shared with you. But if there are any particular resources in regards to this Altera test, what would you like to see? Genetic counseling, appointments, more information on testing. So I'd be happy to kind of open that up, or if anyone wants to put it in the chat for Sonia to read. We'd just like to take a few minutes to get your thoughts on this before we dive into discussion and questions.
Okay, if you have any response to Rebecca's question, if you could please just raise your hand and then we can take, you know, one at a time. And I'm trying to look at everybody's button. So you can unmute yourself. And if you just push the raise hand button, which is down in the reactions section. If you're on your iPhone, just speak out. Okay, we're going to go ahead and start covering some information that's in the chat. Mm-hmm. Okay, let's see. Is the test, is Altera covered by insurance?
Yes, yeah. So also because it's part of guidelines, and I know there is specific Medicare coverage for this as well, like with CMS. And I believe most commercial insurers will cover this as well. Most in the recurrent and metastatic setting will cover at least one CGP or targeted panel test on one sample. They will not cover multiple tests on the same sample. Okay. Is the Altera test available in Canada, and how do you access it if it is? That's a great question. I actually don't know if it's available yet in Canada. Angel or Jamie, do you happen to know?
Oh, go ahead.
I'm unaware. I don't know.
Okay.
I don't believe it's available outside the US right now, but we can check on that and get the information to you.
I will also tell you, in the United States, I know that it is currently not available in New York. New York has special guidelines for CGP testing and targeted panel testing, and we are currently in the process of seeking that approval for the state of New York. So just wanted to make you aware of that.
In the case involving fusion of estrogen receptor gene, where anti-estrogen drugs would not be beneficial, would the patient's tumor be ER negative or ER positive?
So that's a great question. So the tumor is still ER positive at that point. It's just it's the fact that it has acquired this new mutation. So as a result, it's not going to respond as well to anti-estrogen therapies.
Okay. Are you saying through a blood test you're able to tell from an old sample that the tumor markers and mutations are changing?
So I'm going to try to extrapolate what I think that question's asking. And if whoever asked it, if you want to clarify if I get it wrong, please let me know.
It's Susan. Susan, your whole name. Susan from Honolulu.
Okay, Susan. Okay. Oh, welcome from Hawaii.
Yes.
Great. Yeah, I bet you're having beautiful weather today. So the thing about that, and I think, and Susan, correct me if I'm wrong, I think maybe you're asking if perhaps we did the profiling on an old or your biopsy, but now biopsy may be from an earlier recurrence or from your primary. And now you're wondering, okay, I've got this later recurrence. Is that going to be reflective of that? Is that what you're asking?
Actually, it was more in terms of testing altogether. I was listening last week to your session, and I didn't think that we were able to pick up on changes to old samples, but I thought I heard you say earlier that that might be the case with this new test. So to be more specific, I have a sample from a year ago that has not been tested. I had a smaller sample tested, but it wasn't the 20%, not through your test, through something else. So I'm just wondering, my test from a year ago, understanding it could have changed in the last year based on treatment and other stuff going on. Would you, if we could get that sample and you tested it, would you be able to tell if there were any changes to that tissue? Or is that not in the realm of possibility?
Yeah, so okay, that's a great question. So depending on when that sample was collected, that's really a snapshot of where the tumor was at that particular point in time. If you have received therapy after that, and so we know that sometimes different acquired mutations can pop up after therapy. So if you have received some therapy since then, there is a chance, yes, the tumor, or if you still have tumor present in your body, there is a chance that those cancer cells could be slightly different. Now, if again, this all is dependent upon your provider. If they feel that they could biopsy again or get a sample from the new recurrence, that would be the best. But if they're unable to do that, then your most recent sample would probably be your best bet moving forward. But again, that would all be up to your provider and if they feel that they could safely biopsy you where you are right now in this particular point in time. I don't know, Angel, if you'd like to add anything to that.
I mean, I guess the only thing I would add is, I mean, that question actually highlights the differences between what Altera is, or comprehensive genomic profiling, and what Signatera, or molecular residual disease monitoring, what that does. And the purpose of, you know, having an older sample to design Signatera, and the point is to track disease burden, to see how the disease is responding to treatment. If levels are going up, disease is likely progressing. If levels are going down, disease is likely responding to treatment. Now, over time, as mutations continue to occur in cancer, the way the Signatera is designed, where we have multiple, it's a signature of multiple core clonal mutations, it is very unlikely that all of those mutations will be lost over time and that Signatera will stop working in the future, right? So it can continue to be used to monitor treatment response, not to detect new mutations, which is something that Altera could do if a new biopsy is done, or with other liquid biopsy tests that exist out there.
Thanks very much.
Thank you, Susan, for that question. Amy asks, will Signatera continue to work over time with progression and change in tumors, or do you need new tumor tissue from the new tumors that may occur?
I think
Yeah.
it was just answered too. I think you did
Okay.
a good job of just answering my question
Okay.
as well. Thank you.
Okay. How current does the tissue sample need to be? Already on third line treatment of TNBC, and recent sample is from July 2021.
Yeah, so that again, that's another good question. And that reminds me of our question from Honolulu. So really, you're going to want to, your provider will probably want to use the most recent sample. If they're able to safely biopsy the current disease that you might have or the current tumor you might have, they probably will want to try to use that. But if that's not possible, again, they'll want to probably go back to your most recent sample.
And I think we talked a little bit last time about the size of that sample and how big it needed to be. Can you just reiterate that so that everyone knows?
Yeah, so it's really about the content of the sample. So we need a minimum of 20% tumor. So, sometimes when you get a biopsy or sample, there might be normal cells or other cells involved. We really want to make sure what we're getting, there's at least 20% tumor. Again, and especially if we're running both Signatera and Altera off of the same tissue.
Okay. We don't have a person's name, but since this cannot be used for people with bone mets, do you have any suggestions for how to get a biopsy from those who do have bone mets or use the testing for people with bone mets?
Yeah, so that's a great question. And I like I mentioned last week, we hopefully will eventually be in that space for bone mets. At this particular point in time, we can't offer anything for that, but there might be other companies that do molecular testing that might be able to run it off of bone metastases. Yes.
Rebecca, let me also clarify that. Remember that the initial core biopsy and the surgical specimen can be used to design Signatera and subsequently be used to monitor a patient who only has bone metastasis. And that's actually one of the more exciting potentials about how this test could be deployed and help us in the future, which is all of our cases that have unmeasurable disease and are unfortunately unable to participate in clinical trials because there's a criteria that says you have to have a mass somewhere that I can measure. And so, as we continue to generate the data for, how Signatera correlates with response to treatment and lack of response to treatment, future studies might actually include the ability to enroll if you have a positive or rising ctDNA result as a potential eligibility criteria. And then the endpoint would be, does the level go down with this novel agent? Does the level clear? And these are very serious discussions that we're having with the FDA to be able to include that, for those purposes.
Thank you so much. Okay, let's see. Kathy says, would definitely need detailed counseling. That's a lot of information.
This is getting into the question I asked. Yeah.
Yeah. And so one of the things that we could possibly do is either work with work with, Natera could work with clinicians to talk about counseling, but you know how that goes. It's a 15-minute visit, and that's not always the best place. That's why we do these series, is so that we can augment what the clinician is saying to the patient. So maybe if there's a more detailed set of training for specific types or specific information, or maybe when the information comes back.
Yeah, and
Go
that
ahead.
one thing I wanted to mention with that oncology PC email that I sent. So that email that directs you right to our genetic counselors. So, you know, if you know, more information would be needed beyond that, you know, that would be something I'd be interested in knowing from all of you, so I could share that back with the company. But yeah, we would have, that's who is on kind of the other end of that email. And they're all licensed, and they are all kind of able to go through these different results. So for example, if your provider, you know, shares these results with you, and you look over them and you're like, wait, I still don't understand what does TIE-TMB mean? And I'm a good candidate possibly for immunotherapy. What is this? You know, again, if you have questions you figure outside of, you know, meeting with your provider, that email is there to help support that for sure.
Okay, we have a question from Amy. Are these reports updated as new clinical trials come online, and are patients or caregivers then notified?
Yeah, wow, that's a great question. Actually, I don't know. I know hereditary testing is regularly updated, but the Altera reports, I'm not sure if they go back retroactively and update them based on new clinical trials. Janie, do you know that?
I do not. I think we need to ask for sure about that. So on a VUS, on, you know, hereditary, they go back for those.
Yeah, I'm certain that they're not updated, right? This is so dynamic, right? How often trials close and trials open. So, I mean, I would always encourage you to, with your physician, you know, when you first get a test like this and there are no matching trials, to continue to look every so often, because you never know when one might pop up with a novel agent, a novel site that's close to you. But unfortunately right now, no, our test is not updated periodically.
Yeah, I
But
think that'd be really helpful.
Yeah, thank you, Amy. That's really good feedback, and I'll definitely share that, you know, with the rest of our team.
Okay, we have Tara who says, is the test available in New Jersey? I'm having a lumpectomy in New York and get treatment in New Jersey. This happens a lot in our community with the, you know, some people in New Jersey going to New York, and New York going to New Jersey. Also, are there any restrictions on Signatera test in New York?
So no restrictions on Signatera in New York. It's just Altera. And if your provider is in New Jersey and treating you in New Jersey, they order this in New Jersey, you're fine. It's just providers in New York currently cannot order this.
And Rebecca, in your experience, do they have to discuss saving some portion of that sample with their clinician or their provider?
Discuss saving the sample. You mean like if the provider decides to run both Signatera?
When they're doing a lumpectomy?
So often a lot of that stuff's already saved. They bank that tissue in a lot of institutions. But again, if your provider knows about this test and wants to order it for you, like you've decided together that this is a good option for you, then actually Natera works with your provider and their pathology group to already kind of flag that, to know that, hey, we're going to take a piece of the sample.
And I'll just tell you, in our experience, it's not that way across the board. Maybe it's some centers of excellence, but Tara, it's always good to have a discussion with your provider and to tell them that you want that sample kept and you want to be notified before the sample is destroyed. Okay, what is the cost of the test if insurance does not cover it?
So out-of-pocket test. So because I'm, I'll be honest with you completely upfront, I'm not sure about cost, but maybe Angel or Janie know the out-of-pocket test. Usually in medical affairs, we don't discuss like the billing or the cost, but I don't know if maybe Janie or Angel, you happen to know offhand what out-of-pocket cost would be.
I'm actually not up to date on the most recent, but we can get that information, of course.
Yeah. Okay. I'm putting that on my list of stuff to get back to you, Sonia, so you can share with the group.
Okay, super.
Yeah. Okay.
And if you were on the last one, you know, we sent you a guide. We've sent you several different things if you were on the last call. If you have a breast tumor, this is from Sue. If you have a breast tumor and bone mets, is it advisable to say no to a lumpectomy, thereby keeping the breast tumor tissue available for biopsying over time and for trials?
Can you repeat that question one more time?
So if you have a breast tumor, so they have a tumor in the breast, it's spread to the bone, is it advisable to say no to a lumpectomy, thereby keeping the breast tumor tissue available for biopsying over time and for trials?
I don't, if I'm understanding this right, if I'm not, please correct me, but I don't think I would say no to any treatment option from your provider.
That's been definitely advised by your provider.
Yeah. And and again, like, as I mentioned last time, I can't advise on treatment options. Only your provider really can do that. We're really here just to help provide tools for them and for you moving forward. But if your provider has said you know that you've discussed this, yeah, I would not make any suggestions in regards to that. Now, if you're asking me if you have bone met only disease and you want to have the test built, yeah, you could definitely, if your only option really is that original tissue from the lumpectomy or the biopsy, we can definitely try to build it off of that, as long as there's a minimum of 20% tumor content. And again, we work with your provider and their pathology group to figure that out.
And also medicine treatments have become so personalized to your subtype and your mutations that is excellent information to know no matter what testing you're using. Just really have that honest discussion with your provider, and they have a standard of care that they typically follow. So make sure you're saying that and also telling them that you may want to use that tissue for future testing. Okay, Nicole says, if I understood Angel Rodriguez correctly, the Altera test uses a biopsy sample to find genomic markers and recommend treatments. An old biopsy sample could miss recent genomic changes. Signatera uses blood sample to look for increase or decrease of something, ? To indicate disease progression. Signatera does not analyze genomic markers and detect changes in markers. How does the Signatera test compare with the old tumor antigen 27 through 29 test? Does the usefulness of the Signatera test depend on a current Altera test using current biopsy?
Okay, so there's a lot of questions in there. So I'm good ones. Okay, so let me talk about the tumor marker, because you mentioned 27, 29. So we, at this point, I don't believe we have a direct comparison with 27, 29, but we do with 15.3. So 15.3 is another serum tumor marker that they'll use in breast cancer. And so for that, we've actually found that we outperform CA 15.3. We can predict recurrence, and we've published on this. And again, I'm happy to share that paper with you, Sonia. I know that a lot of you like to read the scientific papers, which I think is awesome. So I am happy to share that. But we do have a figure in there where we are able to detect on average using Signatera, we can detect molecular recurrence In that particular paper, it was almost 8.9 months before the biomarkers picked it up. And so we are more sensitive. And again, because this is a test that is built specifically for you and your tumor markers, right? It's that kind of that fingerprint of your tumor. Whereas we kind of touched upon this a little bit loosely last week too, but those serum biomarkers, 15-3, 27, 29, they're not present in every patient. And their levels can rise and fall depending on, different things that are going on. Inflammation can cause them to rise and fall. So really, our test has outperformed in that setting. And we've even shown it comparison with other tumor biomarkers too, not even just in breast cancer. We've outperformed CEA in colon cancer and CA-125 in ovarian cancer. Let's see. And then the next question that she had, could you refresh my memory?
Yes. Okay. So does the usefulness of the Signatera test depend on a current Altera test using a current biopsy?
So Signatera and Altera are not dependent upon each other at all. So the success of one is not going to affect the other. And this gets back into the fact that they're measuring different things. So Altera is really Altera is really looking at those tumor mutations, right? Those clinically actionable genes, potential fusions, tumor mutational burden. None of that is being used in the Signatera assay. The Signatera assay was specifically built off of those clonal mutations that are present at the beginning of the tumor. And they're really that fingerprint to kind of track it over time. So those variants that are present that we're tracking in Signatera are not in the Altera assay. So they are two different assays. So they're not dependent upon each other. I hope that makes that a little more clear.
Okay. And Tara says, I'm having the lumpectomy Tuesday. Anything I should pass along now? And I'm assuming that's related to testing. There's a couple of things that for Tara, are you newly diagnosed with metastatic breast cancer?
No, I was diagnosed in March of 2021.
Okay.
But I have a reoccurrence. So they're
Okay.
taking it out. It's actually they're saying I was stable, but now they're saying that it's a spot in the tumor's in the original spot, but much smaller. So they want to do a lumpectomy.
Okay.
So Tara, for information that you'd want to pass on, so we have those patient discussion guide and pamphlet that we sent last week about Signatera. If you'd like to share that with your provider. And in addition today, I'll be sending, we actually have, because at this particular point, we don't have patient-specific materials for Altera, which is why I asked all of you that question at the end, what would you like to see? So that we can help to work on developing that. But we do have provider materials, and actually I'm going to share those with Sonia today, and she can pass those on to you, Tara, so you can also take that along with what you got last week for Signatera, and you can share those with your provider.
I didn't see what you sent last week. I just tried to look for it and I couldn't find it. So
okay.
Can you resend it to me possibly if I put my email in the chat?
Yes.
Okay. Thank you.
Yeah. So so Sonia will send that again to you, and then also the Altera specific provider content that we're going to share today. You'll get all of that. So you can definitely share all of that with your provider and have a discussion with them at your next appointment.
Okay. And I just want to recap what Angel said in the chat. Old biopsies may miss acquired ESR1 mutations. For example, Signatera will, however, be able to detect progression, at which point it may be beneficial to assess for acquired mutations at that time. Okay, so Sue asks, meaning keep the tumor in the breast, so if it mutates, etc. I'm asking theoretically. So keep the tumor in the breast. I'm assuming she means. Please tell her what you mean. Do you mean remove the tumor and then keep it somewhere?
No, I'm asking theoretically, right? So I'm not asking for specific advice. The bit I'm just not quite understanding what you're so say. Let's say you're looking at a 2 or 3 year timeline. Obviously, these mutations occur over time, so it's better if you presumably, from a testing perspective, if you're having fresh repeat biopsies, right? You want fresh tissue really each time, right?
I mean,
Yeah, yeah.
a little bit. So remember, there's 2 tests here, and then there's 2 goals, right? One goal is to look for new novel mutations that may possibly be relevant to treating the cancer. And from that perspective, you're correct, right? The most recent biopsy may be most beneficial for that.
Yeah.
However, if we're thinking about what we want is driver mutations, the mutations that drive the tumor, those are typically almost always going to be present at the beginning. For example, HER2 positive mutations, most of the time they start off, you might lose it over time, but it's rarely do you gain it over time, right? I'm not saying never, but rarely. Now, the second purpose is that Signatera, for the purpose of monitoring disease burden, right? Is it going up or is it going down? Think of it like a tree, right? Trees right, that you can see mutations. So the tree has a trunk, right? And that trunk is basically mutations are clonal when they're on the trunk of the evolutionary tree, right? And so those mutations are rarely all lost over time. Some of them may be lost, some of them, but for the most part, cancers will retain many of those clonal mutations forever. That's what drives the performance of Signatera to be able to still be detectable even after 2nd, 3rd, 4th line of therapy.
Right.
You always can use that test to monitor disease burden, no matter how many recurrences or progressions have occurred. So those are like those 2 different utilities that you can think about.
Thank you.
And one thing I just wanted to mention, because one of you asked about cost. So Janie was able to get that number. Out-of-pocket cost for Altera is $395.
Amy
Just a
asked,
reminder to always check with your insurance if you have any questions. Also, I'm sure you're all very versed at dealing with your insurance companies.
and some people, Janie, you may not know this, but we're trying to get some laws changed now. Some patients, when they're initially diagnosed, they can get SSDI within like a 5-month period, which is still far too long, but they have to wait sometimes almost 2 years for Medicare. And so if you don't qualify for Medicaid in your state, you're in this abyss where you may not have any insurance, or it may be unaffordable on COBRA. So just FYI, where that's concerned, it's a real problem in this community. So just FYI.
Completely understand, and we also have a compassionate program, so you can always apply to that at Natera also. So just to let you know about that.
That's excellent, Janie. Thank you.
Yeah.
Amy asks, besides the basic report you showed, what else is included in the Altera report?
Yeah, so in the Altera report, you'll also, it will provide references for each of those clinical trials or potential drugs that have been listed. It will also, so it will have all the research papers in the field that have been basically published in that area, proving that there might be some therapeutic efficacy with this. So it's really nice. So if your provider needs a quick snapshot of, well, where's the evidence for this? We provide all of that for them. And if there is,
Sorry.
oh, go ahead.
Is there anything that's more like that hasn't, like maybe that might be in like phase 1 or any earlier? Would there be like a listing of those genes as well?
So things that might be like research use only, is that what you're asking?
Yeah.
Yeah. So I don't believe we have that. It's pretty much only if there are clinical trials or FDA approved therapies. So just because research use only, I mean, it could be months away or it could be years away from getting into a patient, right? So we don't have that, unfortunately. Yeah. But good question.
Yes. Susan, on the materials, we're gonna check on that. It's gonna be coming from Kristen or Kristen at METAvivor. Kathy asks, okay, Kathy, same thing for you. And the only way you wouldn't receive it is if there's an error in the email, but if you're joining today, you probably got a reminder, so your email should be good. Okay, so Carol says, I'm still confused about bone and liver mets. Are you saying Signatera won't work, but Altera would with using regional breast tissue?
Yeah, so it's not that it won't work. It's just that we have to build it off of tissue. And at this particular point in time, if you only have bone disease and the original tumor does not exist, they can't get your biopsy or resection, for whatever reason, unfortunately, maybe they've discarded it. If you don't have tumor elsewhere that is safely biopsiable, unfortunately, we just can't build it off of a bone met just yet.
Can I explain? My mastectomy was taken at Sloan, so I'm assuming they still have tissue.
Yeah, depending on how long ago. I know a lot of large.
2004. That's a long time.
Ask about that because they may not.
Oh, really?
Yeah.
Ask about it. It can be a simple call to you don't even have to speak to your provider about that. Typically their office staff can help.
Okay. So if I do have tissue, then what the answer is?
Yeah, so if you do have tissue, then you can talk to your provider about ordering the test. And then, they would go through, and we have a whole, tissue request form and everything. And we actually have sales people that are present throughout the country that can work with your provider on all the logistics. So they make it as easy as possible for them. They help work with the pathology department to get your tissue, to get it to the lab so that we can run the testing. And then all of your results go through a portal, and then your provider has access through that portal to be able to view your results.
But I thought you said a couple of times that you couldn't really do it with bone mets and liver mets.
So you were asking about if you're
I don't have biopsy from the bone, I don't have a biopsy from the liver, but I've got, if they still have it, tissue from the breast.
Right, and so that's what I'm referring to. If they still have your tissue from the breast,
then we can do.
Yes, then we can, as long as there's that minimum 20% tumor content.
Terrific.
Yeah.
I'll definitely call and find out. Thanks so much.
Yeah, no problem.
Okay. Are there any other questions for Rebecca? I know we're a little bit over time, but we want to make sure all your questions are answered on this because this is so important.
And I just want to follow up too with action items of some other things that we're going to send. I just want to make sure I have everything here because I don't want to miss anything. So I will send a link about that compassionate program that Jeannie mentioned in regards to cost. Again, if this is an insurance option or issue, I'll also share that paper that we have comparing us with serum biomarker. And then I will also provide the Altera provider materials so that you can share those with your provider and have a discussion. And you can use those kind of in conjunction with the Signatera discussion forms that I sent last week. Okay. And all of that, I think Sonia said it's coming through her or through Kristen. Yeah, but if there's anything
info at or Kristen at.
Yeah. And then let me know if there's any material I missed. Happy to share whatever we can to help you and your provider help make the best treatment decisions for you.
I want to thank Rebecca for joining us today and her team at Natera. We just are so thankful to them. And these kind of partnerships help you understand and help you be able to make good decisions with your oncologist and your team of providers. And that's what we're looking for. What's new on the market? What's out there that can help you make those decisions? And we are just super thankful for you. We've got one more program in the series that will be with the Trevera testing, new on the market test that's been created by MIT. And we just thank you guys for joining. And we will be sharing other Lunch and Learn series as new and evolving information comes through METAvivor. So thank you guys for joining, and look for that information in your inbox.
Thank you so much. Our pleasure. And it's always an honor to speak to this group and hear your questions and your thoughts. So thank you for your time. And I wish you all, best of luck in your journey. So thank you.